Adjunct Professor Ruth Stewart is Australia's National Rural Health Commissioner. Are you joining us today from Roma? Is that where you live, Professor Stewart?
Yes, I live in Roma, but I'm on my way back home having been in Canberra meeting with department officials. So I'm in Brisbane, about to catch a plane back to Roma.
Yes, you know the tyranny of distance all too well out at Roma. How are we holding up when it comes? If we give rural health a health check, how is it holding up at the moment?
Look, the health status of rural and remote Australians falls well behind that of our urban compatriots. We in rural and remote Australia have a heavier burden of disease and have a shorter life expectancy. It's not too bad if you live closer to the city, but by the time you get out to remote and very remote Australia, and especially if you're Aboriginal or Torres Strait Islander, First Nations person, your life expectancy is much reduced and as high as 25 years less if you're a female living in very remote areas and Indigenous.
And given those health outcomes, we've got these challenges when it comes to the workforce in rural health. I guess it seems odd that given that those poorer outcomes, we don't have the staff that we need just at the moment.
Yes, well, until now, there has been a disconnect between the levers for workforce, how we organise workforce, and the health outcomes and health status. It's probably partly because we have much better data on the health of Australians now than we did even 20 years ago, that we realise how acute the situation is. When I was a young girl growing up in rural northern Victoria, we all just assumed that we had much better health in the country. But in fact we didn't, we just didn't know it. Now we know that the health of rural and remote Australians is poor, and we know the sorts of things that are problems for us, such as cardiovascular disease, obesity, higher levels of smoking, of dangerous drinking, and lower exercise. Health professionals are aware of what the issues are. We just don't have enough health professionals in rural and remote areas to communicate those issues and assist rural and remote residents to improve their health.
Now, you've just dropped a mention of northern Victoria. Can I just digress for a moment there? Just tell us a little bit about where you grew up. It might be one of our broadcast areas.
I grew up in Tatura. I'm a Tat girl.
Right. Well, they're very good. Just tell us a bit more about the role of the National Rural Health Commissioner. I mean, what are some of your primary responsibilities or things that you do in that role?
So the role is a statutory officer role, created by legislation. I report to the Assistant Minister for Regional Health, who is Emma McBride. And my roles are to engage with community and key stakeholders in rural and remote health to look at workforce issues, to assist the government to develop policy to improve the health status of rural and remote Australians. That's a sort of overarching responsibility, but with a focus on health workforce, on developing the workforce for the future, increasing the involvement of First Nations people in the health professions. And one of the things is that we must remember that there's a whole multi-disciplinary team that delivers healthcare in Australia. We have doctors, we have nurses, nurse practitioners, we have allied health practitioners, pharmacists, and we have Aboriginal health workers. So it's the whole team, and I have a responsibility working with my deputy commissioners. I have two deputies. One is Faye McMillan, who has expertise in allied health and was Australia's first Aboriginal pharmacist. And the other is Shelley Nolan, who is a nurse. Her other gig is as the Chief Nurse and Midwifery Officer in Queensland. They help me by engaging with their professional groups and focusing on the issues within those groups. But we work very much as a team and bring all of the issues together.
Now, one of the issues you mentioned several times in our chat so far has been the health workforce. It does seem the two buzzwords in the commentary around this are visas in the short term and training and encouraging local people perhaps to take up medical careers and remain in local communities. What are some of the initiatives you're hearing or are being trialled in that area?
So Australia has been leading the world in developing both the theory and practice of rural clinical training. Some of your listeners may remember that back in the day, nurses were trained in all hospitals, no matter how small they were, and then nursing transferred across to universities, and we were no longer training nurses in rural and remote communities. But the medical training was always in Australia in the universities and therefore in the large hospitals. What we have come to understand is that health professionals are likely to work very close to where they are trained, and so if you're only training them in the cities, it's really difficult to get them out of the cities and into rural and remote communities. The Australian government, about 25 years ago, started what has become the Rural Health Multi-Disciplinary Training Program. Began with rural clinical schools for medical schools and university departments of rural health, which supported the rural training of nurses and allied health students. So those programs, we didn't get it right in the beginning. We probably still have changes and improvements that could be made. But year by year, we're gaining a much stronger understanding of what interventions actually make a difference. And the ones that we know make a difference are that you need to take rural students into the health professional programs. The best indicator of which of your students will become rural practitioners is that you look at those who are from a rural community themselves. But we know that if you give students early, well-supported clinical opportunities, clinical training opportunities in rural and remote communities, that's what opens their eyes to the opportunities. And if you keep repeating those clinical attachments in rural and remote areas throughout their course, the more exposure they have and the more often it's repeated, the more likelihood you have of creating a rural or remote practitioner at the end of the course. So early, often repeated clinical attachments through the course, that helps. Then you give them explicit rural curriculum. So tell them about rural health, tell them about what makes a difference, how they can work in rural areas and how they can improve the health of rural communities. And then give them a clear line of sight to a job and an understanding of what training they need after they graduate to work in those jobs. We talk a lot about the Rural Generalist program in medicine, and there is also a Rural Generalist stream in allied health for many of the allied health professions. And within nursing, Shelley Nolan, Deputy Commissioner, has worked with a team to create the nursing rural and remote generalist framework. And that will be released very soon by Assistant Minister McBride, and that will give nurses who are interested a very clear description of the skills that they need to work in rural and remote areas. And we know that there are already universities who are looking to that framework to set up curricula to train nurses for rural and remote generalist training.
And I notice, and you've got quite some experience in rural generalist practice yourself, there has been a lot of concern expressed about the declining number of medical students that are studying general practice. I guess there's some of your work feeding into trying to promote general practice as a rewarding career?
My word, it is, yes. I am a rural generalist, and that's a subspecialty of a specialised field within the specialty of general practice. Well, it's not officially yet. We have an application with the Australian Medical Council for recognition of rural generalism as a specialised field. But I trained as a general practitioner. I also got training to become a GP obstetrician, and so I worked particularly in Camperdown in southwest Victoria. My husband and I were there as GP obstetricians for 22 years, giving, cradle to grave care. Just a wonderful, wonderful job and a wonderful lifestyle and a great thing to do. Really, the only reason we moved on was that I was frustrated with the low numbers of, not low numbers, there weren't any junior doctors following us, and I thought, well, they must be doing things wrong in the university, so I got a job in a university.
I thought you'd try and fix the problem.
Yeah.
Yeah, look, and that's a common frustration we're hearing in the GP space across the country. Is sometimes you get one GP in some towns and they're just constantly on call.
Yes. It's too hard to work as a solo GP. My office is leading a lot of discussion about the rural health multidisciplinary team, both to recognise, though, that in rural communities we actually work in multidisciplinary teams, to make it explicit so that people understand that, but also to help people understand that a lot of different professions have skills that when we bring bring ourselves together as a team, we can provide much broader services and we can support each other. So a multidisciplinary team can make a really big difference, so that GP if a solo GP can be working closely with nurse practitioners and with paramedics, then their burden is much reduced. So my office led a summit called Ngaya Gadan, coming together, talking about and finding a definition for the rural health multidisciplinary team. Yep. And sorry, I keep interrupting you.
That's all right. Professor Ruth Stewart is the National Rural Health Commissioner. Just before we go, talk to us, if you could, about high school. I'm just thinking, are we doing enough to promote and encourage rural health careers, especially in rural high schools, for young people? They might be a bit squeamish about the idea at first, or a bit scared about how much work you might end up having to do in a rural community as a generalist. But is there some way we can promote that to encourage even younger generation to start thinking about a career in that direction?
Well, Ricky, I think that you can do a good job in promoting it. Rural kids can become nurses, doctors, allied health professionals, Indigenous health workers. Rural kids can do it. There are now much better, methodologies to support rural students at university, but also the courses are coming out into rural and remote communities. So there are a number of medical schools around Australia where you can now be in a regional town studying medicine from year one. so that we know that for some rural students, the thought of moving to the city is just too overwhelming. Some are keen to get there and can't wait, but for others it's just too overwhelming. You don't have to move to the city for a start, and there are plenty of routes to get into these courses these days. If you do a biomed science or a science degree, a public health degree, and then you can look at a postgraduate medical course, postgraduate nursing course, and you can come in via the VCAL pathway too. There are many different routes to get into health professional training. Think about it. You could be a doctor, a nurse, speech pathologist, radiographer, dentist. It's possible.
Yep, the list is endless and endless opportunities, and they're desperately needed, those jobs to be filled in regional Australia. National Rural Health Commissioner, Professor Ruth Stewart, thanks so much for sharing your time with us today, and we'll keep this conversation going, encouraging careers in rural health.
That's fantastic, Ricky. Thank you very much for the opportunity.